Right, this is the second part of chapter 2. We're going to talk about enteral drugs now. And this is all starting on page. Oh, let me see. Oh, it's going to be on page 31. That's where we're going to start with. Okay, so when we're talking about enteral drugs, these were given from outside into the GI tract. And there's three ways of us getting into the enteral route. Remember, that is the biggest way we're going to be giving medications. And the first one is the mouth. That is oral cavity, and people swallow pills every day. The second way that enteral drugs can get in is through feeding tubes. We can do nasogastric tubes or NG tubes, where it goes in the nose down to the stomach. We can do percutaneous endoscopic gastrostomy tubes, which are PEG tubes, or G tubes, which are gastric tubes. So those are the feeding tubes that we can give. And then the last one is the rectum. And so those are the three routes that we can give for enteral drugs. Now, when we're talking about oral drugs are given by mouth. It's usually written order as PO, which means per os, which is PER, and then the new word is OS, means per os, which means by mouth. So whenever you see the PO, all it means is by mouth. And we can give them by tablets, capsules, liquids. They're easy to give if a patient can swallow. It's not an issue with that. If we give too much, then we can pump it out of the stomach, or we can actually induce vomiting if that is a necessity. A lot of times they don't encourage that anymore. Or we can actually give activated charcoal to deactivate if they overdosed on something. It's not really good to give oral forms of medication if a patient is having nausea and vomiting, because what they're going to do is just get sick on the pill. And if they're vomiting, they're just going to vomit right up. So the enteral route is a lot of times the oral one is not very effective for that individual. Usually they're easy to give if the patient can swallow. If you give too, so that's the best thing. That's why I said it's great on that. But the bad part of it is, even though it's easy to give if they can't swallow, the action and the onset is slower. Because it needs to absorb through the GI tract. So even though it's easier to give, because if they can swallow, it takes longer for those medications to kick in and take effect, because they have to absorb through that system. So before we give, we always want to make sure, can the patient swallow? And we can ask the patient, are you able to swallow? We can do some testing to see if they can swallow. If they can swallow fine, then we're good to go. We want to make sure we sit the patient in an upright position. We don't want them laying flat on the bed, although I've seen it many times, and it's like, wow, how do you do that? You want to make sure you wash your hands. You want to make sure you have a full glass of water ready for them to drink. And you want to tell them what meds you are giving and answer any question that they have. Excuse me. A patient has a right to know what they're getting, and they should probably ask you what they're getting. That's just appropriate. I want to know what you're giving me. I'd be like, so what are you giving me today? Even though it could be my daily medications, I want to know. And also you want to make sure, answer those questions. If you don't know something, then it's something that you're going to have to look up and find out for that patient. You also want to tell them if there's any special precautions for the medications, like any safety precautions, like do you need to, maybe call if this medication will make you dizzy. You may have to call me so I can help you out of bed because I don't want you to fall, or sit a little bit before you stand up. So those are some safety precautions that we have to. Please use your call light. I understand that, these medications can make you not feel right. I want to be there for you. Make sure you also teach them, place the med in the back of their mouth, take a few sips of water, and then swallow the drug. You'd be amazed how many adults cannot swallow pills. But it's the same thing like swallowing food and all that. You just want to make sure you teach them. They have to put it to the back of their mouth, few sips, and a big swallow down. Another thing is, afterwards, they want to drink a full glass of water unless they have fluid restrictions, because the water is going to help dissolve the medication better and cause less GI upset. So that's a nice thing. Another one, you want to stay until the drugs are swallowed. Don't leave the drugs at the patient's bedside to take later. If they're not going to take it, make sure that take them with you. If they're not going to take it right away, tell them, I will be back, and then I'll be back, and then I will give. And then last thing that's very important is to make sure you document that you gave medications. Okay, that is the most important because remember we talked about drug errors. Um, and there's different forms. If you're giving a liquid form, make sure you shake the medication. Sorry about that. So the liquid form, like I was talking about, make sure you shake it very well. Use a medicine cup and always be at eye level. An example of that is on page 33, figure 2-4. You should always be at eye level to make sure that you're getting it correctly. After you give that oral drug, like I said, document whatever you've done, most important. If the patient refuses or not given, document why, but always document that they refused it, and you can document a reason why they refused it. And always recheck later if you did give a medication. Always recheck the patient for any side effects or adverse effects. Also, desired effects. For example, did the pain medication help? And if it did, that's great. That's what you wanted. What level are you now? You were at a 10. What are you now? Oh, you're at a 5. That's excellent. It's gone down some. If they were nauseous, are you nauseated anymore? If you are still nauseous, maybe we can get you something more. And if your blood pressure was high, we gave you a blood pressure pill, maybe it came down some. So always recheck and make sure there's no side effects, adverse effects, and make sure that we got the desired effect that we wanted. So now we're dealing with oral drugs given by feeding tubes. Now, these are patients who cannot swallow. Maybe they have some trauma, neurological issues. Maybe they had a stroke where they're unable to swallow. These are individuals where you're going to see, maybe they just had surgery. That could be too. So these are the patients that you're going to see with a nasogastric tube, an NG tube, a G tube, a gastric tube, a PEG tube. These are, when you see the order, it can be written as PO, and we know that's per os, which is by mouth, but you can still do it for a PEG tube. So it can either be written PO or it could say NG tube, G tube, PEG tube. These are the ones that you want to make sure that you are able to crush the medications or open the capsules. And if you are in doubt, you would definitely call the pharmacist. But we know any meds that have the XL, SR, any of those things, you can never ever crush those medications. Definitely call the pharmacist and see if there's an alternative. Make sure we wash our hands. We're going to make sure we place the patient in an upright position. Why do we do this? Well, we do this because if you lay them flat, you have a risk of causing aspiration to that patient. So anybody with a PEG tube should always be at a angle, at least 30 degrees or higher, because we don't want them to aspirate. We would never lay them flat. We also want to make sure we check to make sure the tube is in the stomach, especially if you have a nasogastric tube. Those tubes are in the nose and down to the stomach, and it's held by a piece of tape or some type of device to hold it. If that patient moves, it could get dislodged and go into the lung, and that is not what we want to dump some medication into someone's lung and cause them to aspirate. So we want to make sure that the tube is in the stomach. We can aspirate or withdraw stomach contents with the syringe, or we can attach something called an end-tidal carbon dioxide or a CO2 detector to the feeding tube. And if carbon dioxide is present, then there's a big chance that that tube is in the trachea and not in the stomach. And if CO2 is detected, we would definitely not use that NG tube. We would probably pull it and have to reinsert it because we do not want to give anything through that tube. It has to go into the stomach, not the lung. Patients on tube feed, you definitely want to check the residual in the stomach. That's the amount of tube feed in the stomach. Remember, some meds do not absorb well if you have a lot of food present. So you may need to hold that tube feed for a little while and wait a little bit to give the medication. For example, phenytoin, which is Dilantin, does not work very well with tube feed. So a lot of times we have to hold the tube feed for a little bit, give the med, wait a little bit, and then start the tube feed back up. If we're giving liquid drugs, we want to make sure that we dilute them and flush them through the tube. If we're doing capsules and tablets, we may have to crush them, dissolve them in some water before we give them. And when we do that, we want to attach to a large syringe, and we'll actually pour the medication in the top of the syringe and let gravity do its work. Now, don't worry about this. You will learn this all in lab. I'm just going over some basic stuff that you know, for each of these, but you will go over these in lab and learn how to do the medications, how to do PEG tubes and that. And you will do them on the clinical siting. After you give any meds through the NG tube or a PEG tube, you want to make sure you flush that tube until clear. Don't leave the medication particles in there. You're going to plug the tube up. Make sure you flush it. Use at least 50 milliliters of water to prevent clogging. If the NG tube is to suction, maybe they had surgery and they're sucking out the contents of the stomach, you have to clamp off that tube for 30 minutes after administration, so the drug has time to absorb in the GI system. If you hooked it back to suction, whatever you put in, the patient is going to suck right back into the canister. So that's why it's important, if they are to suction and they're getting stuff through the NG tube, you clamp that for 30 minutes before you restart it to suction. And document everything you've done. So that is with dealing with PEG with the enteral route. Now, the last part is the rectal drugs for the enteral. Patient, if they have nausea and vomiting, this is probably a good route for them to use, is the rectal. It's a form of a suppository. It can be an enema. The suppositories can be wax bullets. They do melt with body temperature when inserted into the rectum. So that is one thing, they will melt. This route is not as dependable or predictable than the oral. Think about a patient who has diarrhea. This is not the drug of choice route for you to give, because they're not going to be able to hold it into their system long enough to absorb the drug. It's just going to excrete right out with the diarrhea. Also, the amount of stool in the system can, affect the absorption. If you are constipated and you have a lot of stool, it's not going to be able to absorb very well. So what do we do before we give rectal drugs? We're going to ask, are you having any diarrhea? Because we're not going to give it if you have diarrhea. We wouldn't want to use this route if you had recent rectal surgery or trauma. If you vasovagal reactions, because if you vasovagal, you could actually, insert this and cause a patient to have a slow heart rate, because their blood vessels dilate and it will cause them to faint. So that can happen. You want to make sure you have gloves. You do not need sterile gloves. This area is not sterile at all. And you want to make sure you give lubricant, because that's nice. Have the patient lie on their left side with the leg on top in a bent position. That's called the Sims position, and you can see that in the book. That is the best. And make sure to cover the patient as much as possible, because this can be very, very, very embarrassing. Like I said, wear gloves, unwrap your suppository, apply lube to the pointed end. Do not insert the blunt end. Insert the pointed end first. And then you want to make sure you insert your finger into the rectum at least an inch in. So you're going to push the suppository and your finger up to an inch into the rectum to make sure the medication. You can have the patient take some deep breaths and bear down. And this is when you want to insert that suppository. So that's very important to make sure you do that. Afterwards, have the patient remain on their side for about 20 minutes to make sure the medication gets absorbed. Wipe off excess lube from the rectal area. Remove your gloves, make sure the patient remains covered, and wash your hands. And always recheck to make sure that the medication worked, and of course, you're always going to make sure that you document everything you did. So those are the enteral routes that we're talking about. Like I said, you're going to learn those more in lab. Now with the parenteral drugs, these are the ones that are injected into the skin. We have intradermals, we have sub-Qs, IMs, and IVs. We use this route when patient can't take oral drugs. It's needed fast-acting route meds, need constant drug blood levels. Drugs that can't be given oral, like insulin, there's no oral insulin. They are all sub-Q, and we can give them IV also. Everything you need to wear gloves except for PO. Those are the only, unless it's a chemo drug or a drug that can cause a lot of infertility or issues that can soak through the skin. But otherwise, you do not have to wear gloves for anything. But for the parenteral routes drugs, you have to wear gloves for all injections. These are the ones that we're going to use needles and syringes. Very important to remember, never, ever recap needles, and make sure we dispose of them in the appropriate containers. Now, when we're talking about intradermal drugs, these are ones that are injected between the layers of the skin. We can use the inner part of the forearm. We use them for allergy tests. We use them for local anesthetics. We can use them for TB testing. It's a small amount of drug that is injected in between the epidermis and dermis layer, and you can see that on page 35, figure 2.7. Usually the little bump that is called a bleb, that is the medication that is injected under the skin. Usually you inject about 0.01 to 0.1 milliliters of solution. You always use a small, short needle, small gauge. Usually it's 3/8 inch or a 25 gauge needle. Of course, before you give, you want to make sure you wash your hands and put gloves on. Clean the area with alcohol in a circular motion from center out. Insert the needle with the bevel up at about 10 to 15 degree angle, and don't aspirate because you can cause a lot of damage. Inject the med until you see that small bump or bleb form, and never massage the area. If no bleb, that means you injected too deep and the test will not be accurate. And what you have to do is you have to redo it in a different site. Afterwards, you give it, you want to document where you gave it and the location. If it's an allergy test, you're going to be looking for reactions, but those can happen to hours to days after. And if it's a TB test check, we always check that in 48 to 72 hours after injection. So those are intradermals. Now, sub-Q injections, we're going to do a lot of those, especially insulins are given sub-Q, as well as low molecular weight heparin, enoxaparin, as well as heparin. So those are some things that we will be giving sub-Q. These are injections between the skin and the muscle. Some common sub-Q drugs, like I said, are insulin, heparin. They're absorbed slower than the IM, so intermusculars are a little faster. They're slower to absorb because they're in the fat. They usually can give 0.5 to 1 milliliter of fluids. We use small, short needles, about 3/8 inch, 25 to 27 gauge needle. And usually the sites, you can use the upper arms, you can use the abdomen, the upper back, your back fat, as well as your thighs. You want to make sure you rotate the sites to prevent tissue damage, and you always want to make sure that you teach the patients to rotate the sites so they don't have tissue damage. Before we give them, we want to make sure we wash our hands and wear gloves. Needles are going to be given at 45 degree angles. For obese people or people who have a lot of fatty area, you can go at a 90 degree angle. If they're very thin, you may need to go less than 45 degrees, just depending on the patient. Never aspirate before injecting the medication. If you aspirate, this can cause a vacuum and can cause tissue damage and bruising, and we do not want that. Afterwards, if there's some bleeding, apply some pressure. Don't rub, just apply pressure. Document where you gave it in the site. Monitor the patient afterwards for any side effects or adverse reactions from the medications. So that is sub-Qs. And anytime you do a sub-Q, I always remember you squeeze the fat. So you want to make sure you get a good fat patch and squeeze the fat before you inject. Now, when we're dealing with intermuscular, that is the IM, that is going into deep muscle. It absorbs faster, okay, not as fast as IVs, but it's the second fastest route, IM. You can take about 1 to 3 milliliters of fluid, no more than 2 milliliters in an adult arm. You cannot do more than 2. Infants and children's, no more than 1 milliliter. And sometimes you have to divide the doses for kids into a couple of shots. Needles are going to be longer. They're going to be 1 to 1.5 inches, and they're going to be larger gauges, 20 to 22. Usually sites, we can use the upper arm, which is the deltoid. We can use the thigh, the vastus lateralis. And we can use the hip, the ventogluteal muscle, which you can see on page 37, the different sites. IMs are always given at a 90-degree angle. Beforehand, we always want to make sure we wash our hands and wear gloves. We're going to cleanse the site using alcohol, 90-degree angle, and we're going to inject it into the muscle. Again, no aspiration for IM vacuums or immunizations. We would never aspirate. And actually, they're teaching you now not to aspirate for any injections at the moment. If you aspirate for antibiotics, exactly like penicillin or other drugs, if you see blood, it means you're in the vein. You have to remove the needle, discard the medication, get a new syringe and med, and start over. But anymore, like I said, they're not really teaching. I mean, I can't say I've ever had a time where I've aspirated back and I got blood. There hasn't been one time that has occurred. So they're actually getting away from aspirating medication. But just so you know that some people do aspirate still, and if you would see blood, that means you're in a vein. You would have to remove it and get a new batch of medication and start over. There is something called a Z-Track form, and like I said, you can learn this in lab, but it's on page 38. It's a method in which they use for medications that are very irritating or can cause some staining in the tissue. It's a lot of times drawing up the med in the syringe. You usually drop like 0.1 to 0.2 milliliters of air extra. The extra air makes the med not ooze out the pathway of the needle and stay in the muscle. Of course, you want to clean the site, pull tissue laterally, hold it and inject the needle, release the med, let go of the tissue as you pull the needle out, which allows the skin to slide over the injection and seal that drug in the muscle. But this is something definitely you want to see in lab in practice because it's very interesting, and we do use it, not that often, but we do use it for certain things. Afterwards, apply pressure because it can bleed, and of course a Band-Aid, and chart the site in administration, and of course afterwards recheck your actions and check for the adverse side effects. Now IV, these are injected into the vein. It's for given large doses. We can give medications rapidly. We can give fluids rapidly. It's for emergency drugs. A lot of the drugs we have to slowly push over minutes. Sometimes over a few seconds. We can put them in IV bags, like piggyback bags, and you'll learn about that when you deal with IVs, antibiotics. But on page 79, figure 5.1 is actually an IV that infiltrated. So it's very important to make sure that our IV sites are really good. Remember with your IVs, these are the ones that are going to be quicker. These are the ones that give you that 100% bioavailability, so it's going to be there. These are going to give that more instant gratification that patients want. So we need to make sure we monitor those IV sites. RNs are the only ones that push meds. LPNs cannot. LPNs can do IV bags, hang fluid bags. They can also do antibiotics. So you can hang bags, but you can't push antibiotics. You can only hang bags of antibiotics. You can do flushes. That's important. But like I said, any type of pushes you cannot do at all. You want to make sure you always check the site for signs of infection. You want to make sure if any fluid going around, that's an issue. If infiltration, it collects into the tissue. But if you see any issues, then stop the IV site so it can be changed. So that's important. All right, so those are your parenteral routes. Now we're going to talk about percutaneous drugs. Now, percutaneous drugs, these are drugs that are absorbed through the skin and mucous membranes. They can be affected by the size of the area covered by the drug, the concentration or strength of the drug, how long the drug is in contact with the skin or mucous membranes, and the condition of the skin. Do you have any breakdown? Is your skin thick? Are you hydrated? How's your nutrition and your skin tone? So we're going to talk about percutaneous drugs. So these are all the things that absorb through the skin and the mucous membranes. Now, the first one we're going to talk about is topical or transdermal. These are applied to the skin. They're patches, they can be creams, they can be ointments. These are going to be topical drugs. They apply in thin layers. You never want to use more, and you don't want to slather on a lot. You just put enough on to that area that is prescribed, not over your entire body, just the area. Transdermals, you want to make sure you apply to the skin and it travels into the bloodstream, so it will maintain a nice steady blood level of med. Now, when we're talking about putting patches, especially on kids, as well as your confused older adults, make sure you put them on the back of the patient so the patient can't pull them off and put them on you. So any type of patches or creams that you have to put on the skin, and it comes on paper, put it on the back so the patient can't pull it off and reach it. So there's many different types. We have nitro paste that we can put on. We have birth control. There's nicotine patches. There's pain patches. That would be transdermals. Patches or ointments we have, they can adhere to the skin. Common sites, we can put them on the chest, the flank, the back, upper arms. We want to make sure we rotate the sites. Before we give the meds, we always want to make sure we wash our hands, and these are the ones we have to wear gloves because they will soak through the skin. Clean the area going to apply the med. Thin layer, if it's topical ointments, transdermal, always make sure you remove the old patch. So before you dose them with another dose, clean the site off after removal, rotate the site, and don't apply to any skin that is broken down. And also another thing is, do not shave. If the patient is hairy, do not shave them before you apply the medication, because if you shave the skin, it causes some dermal microabrasions or irritation. And what happens is, if you put that medication on there, it's going to soak through the skin faster because you caused some abrasions in there. And you don't want to do that. And that will cause the medication to actually absorb quicker in the system. So never shave. You can use some scissors to trim off. You can actually use wax where you put the thing and rip off the hair, but never, never, never shave it. Afterwards, document where you gave it in the site, because it's always important to know where it's site, because you'd be amazed how many patches migrate and find somewhere else on the body. Always put the date, time, and initials, your initials on the patch, and always check for any side or adverse effects that are occurring afterwards. Now, when we're dealing with this categories with the mucous membranes, there are different types. We have buccal and sublingual drugs that deal with the mouth. We have drops and ointments like the eyes, nose, and ears, which are sterile procedures. We have the inhaled ones, which are the lungs. We have the suppositories and creams, the vagina. Drugs are well absorbed through these areas. The blood supply varies to different areas. So depending on where you give it, depending on what the blood supply is and how it absorbs. But always wash your hands and wear gloves whenever you're dealing with this. So when we're dealing with buccal and sublingual drugs are placed between the cheek and molar teeth of the upper jaw. And you can see that on figure 217 on page 39. And sublingual is under the tongue. Patients shouldn't eat or drink until the medication is dissolved. Never swallow or chew the medication. It needs to absorb through it needs to absorb through the mucous membranes. So you want to make sure they leave it there until it completely dissolves, and then afterwards they can eat or drink. These medications are not absorbed in the GI tract. Ear drops on their hands should always be given room temperature. Always wash your hands and wear gloves. Have the patient lie down with the affected ear up. Now, this is very important. If you're 3 years old and younger, you pull the earlobe, the pinna down and back. So you're going to pull down and back if you're 3 and younger. If you're older child and an adult, you pull the earlobe up and out. Okay, and I always think of like an older kid. If I'm going to grab them, if they're running away from me, I grab them by the upper part of the ear and pull them back. So that's how I can remember, pull up or pull down. But this helps straighten up the ear canal, and you can see this on page 40, figure 219. But you need to know the age group and which ones you pull up and which ones you pull down. These maneuvers will straighten that ear canal, like I said. You definitely do not want to touch the eardropper to the ear. You want the patient to lie down for at least 5 minutes, and you can use a cotton ball if ordered. Then you would have them do the other ear after 5 minutes. Now, eye drops we're going to learn back in chapter 29, so we're not going to talk about that now. And then nose drops, drops or sprays, you definitely wash hands and wear gloves. You want to make sure you drop the med. Have the patient gently blow their nose and lie down with their head hanging over the bed. Instill the med in the nostrils. Don't touch the dropper to the nasal thing. If it sprays, patients, a lot of times they need to sit up. You block one nostril, you put the medication in and have them inhale, and then you would do it to the other side. Make sure you wipe the bottle and repeat with the second nostril if ordered, but this will absorb quickly. Inhalers, we're going to talk about inhalers in the respiratory tract when we talk about that in chapter 21. And then the vaginal drugs, these could be creams, jellies, tablets, foams, or suppositories. They are given at room temperature. We want to make sure we have the patient empty their bladder first before they lie down. We're going to wash our hands and we're wearing gloves. We're going to make sure if it's a suppository, we lubricate the suppository. We're going to, if they have special applicators that, we have to apply the cream. We want to make sure we insert it in the vagina until we can't insert anymore. And then we want to push the med up with the plunger. And then afterwards, we're going to make sure we clean that plunger. Have the patient lie for about 10 to 15 minutes after we give the medication. So that's very important too. But after all, with percutaneous route drugs, we want to make sure we document it and recheck their effects. Now, in the back of the book, there are many ways of how to give the medications. Okay, there's different, and I think they start on page. Yep, in the back. And you guys have to kind of need to know this because I do orders of medications. So this is the time to start looking of how to do it. But it actually starts on page, on page 501. It's medication, like medication administration skills, like the orders of giving the med. What should you do first? What should you do second? I don't care about the gloving and that, but administering the tablets and pills and capsules important. How to do liquid medication, how to do sublinguals, how to do buccals, how to do eye ointments, eye drops, how to do ears. Now the eyes drops and, like I said, inhalers, we won't, that will be back when we learn about those chapters. But you need to know how to do nasal drops and how to do any inhaler stuff. So these are things to look at because these are like rectal suppositories as well as vaginal suppositories. You need to know how to do those. So start looking at those and try to remember how those go. So that is the end for chapter 2. And like I said, if you have any questions, definitely get a hold of me. Usually the first test that we have covers chapters 1 and 2 because it is, like I said, it's the meat and potatoes of pharmacology and it's very important. So go through the information and, like I said, it's going to be more based on pharmacological things, not biology. All right, you guys, have a good one.